Thanks for trying this option here with looking at these presentations in this type of format since it's snowing outside and we're not able to get together in class. We started with central nervous system infections in class, but I'm going to start from the beginning again. That way you have a recording of everything that we've talked about up to this point. So if you remember, an infection in the central nervous system really is an important problem because it requires you to recognize the issue and initiate therapy pretty quickly, as this can become a life-threatening infection rather quickly. The clinical syndromes that we're going to talk about here are going to be acute bacterial meningitis. That should be viral meningitis, not vital meningitis. Viral meningitis, encephalitis, and then focal infections such as an abscess. So the early syndrome presents generally with this non-specific symptoms of fever and headache, and that can be any of the central nervous infections, whether it's encephalitis or viral meningitis. Most patients typically will present with a headache and fever. This becomes a bit of a problem because so many people will present with symptoms of headache and fever that don't have a central nervous system infection. For instance, this time of year, the flu is, quite apparent in our population. And most of these patients that are presenting to the emergency room or the family practice office are complaining of fever and headache and body aches and chills. And you can have all of these symptoms too with a central nervous infection. The difference here, or the things that you want to be careful for or to watch out for, is that when the central nervous system does have an infectious process taking place, it can progress to a change in mental status, focal neuroscience, particularly if you have increased intracranial pressure and even seizures. The key goals for you is going to be to distinguish between these conditions urgently, identify the possible pathogen through a CSF culture, and then initiate the appropriate antibiotic therapy. All right, so let's talk about bacterial meningitis. This is a big problem in our country because it can kill you pretty fast. It's an acute purulent infection, generally within the subarachnoid space. Purulent, remember, meaning that this is a medical term for pus, which is broken down white blood cells. So as that accumulates in there, you get this, what's known as this purulence. It is associated with central nervous system inflammatory reaction, which can result in a decreased level of consciousness, seizures, and raised intracranial pressure. Remember, with any inflammatory process inside the cranial cavity, the brain will begin to swell. And as that swelling takes place and that edema seems to follow, the brain has nowhere else to go. So it's going to keep building up pressure inside that solid cavity, and one way or another, it's going to try and release that pressure through a release valve, aka your foramen magnum. And if you don't address this early enough and the pressure gets to be too much, you run the risk of herniation at that point. The meninges and the subarachnoid space, along with the brain tissue, the actual parenchyma itself, all can be involved in the inflammatory process. So you can easily have one process that leads into another process, from a meningitis to an encephalitis to a focalized infection. It all just depends on the pathogen and the pathophysiologic process that's taking place. So bacterial meningitis is the most common form of suppurative, aka pus, bacterial CNS infection, with an annual incidence of a little bit over 2.5% cases for every 100,000 people in a populated area. The most common organisms for this community-acquired bacterial meningitis is going to be strep pneumo, Neisseria, group B strep, and listeria. You need to know these organisms because it's going to become important when you choose empiric antibiotic therapy. So when these patients present to your emergency room or family practice setting, you're not going to know what organism is causing their bacterial meningitis. You're just going to have a strong index of suspicion that it's bacterial meningitis. You're going to do a lumbar puncture on them and you're going to send the cerebral spinal fluid to the lab. But you can't wait to get a culture result back. That can take days. Even a gram stain is going to take a few hours. You can't delay giving your patient antibiotics. So knowing the common antibiotics, or excuse me, the common um, bacteria that get involved in this process will help you select an appropriate antibiotic as your empiric therapy. Once you have gram stains and culture reports back, you can fine tune your antibiotic regimen, but in the meantime, you need to start with empiric therapy. H-flu was common, but since the invention of the Hib vaccine, we have seen a significant reduction in cases causing meningitis. Neisseria is a pretty significant cause of recurrent epidemics, particularly in ages 8 to 12. Strep pneumo is the most common cause of meningitis in adults. And if you looked at the previous slide, I'll go back, you can see that it accounts for about 50% of the cases there. So strep pneumo is the most common. It accounts for, like I said, 50% of cases. Mortality rate is around 20%, even with antibiotic therapy. So this is why it is so important that you recognize this and get antibiotics on board. I mean, think about that. 1 in 5 patients will die as a result of this, even with antibiotic therapy. That's a pretty significant number. Risk factors for developing strep pneumo bacterial meningitis would be a pneumococcal pneumonia, meaning you had strep pneumo as your cause of your pneumonia. That's the most important cause there. Because if that spreads and it gets into the central nervous system, then absolutely it can cause a meningitis. Coexisting or chronic pneumococcal sinusitis or otitis media. As I mentioned to you in class, strep pneumo is a pretty common organism to cause upper respiratory type infections, and that can lead into things like sinusitis and otitis media. And as we discussed in class, if you have a pretty significant sinusitis or otitis media that doesn't get treated, those things are really close to the central nervous system, and should those bacteria migrate across the barriers, you're going to be in real trouble here. Alcoholism, diabetes, patients with splenectomy, as you've learned about in hematology, your patients who are functionally asplenic, such as folks with sickle cell anemia, they actually fall into the criteria to get the pneumococcal vaccine because they can't fight off encapsulated organisms such as strep pneumo. So it's going to be really important that those folks get the vaccination to prevent them from illnesses such as bacterial meningitis. Hypogammaglobulinemia, these is just people with some immunosuppression there, people with complement deficiency. Why? Because they can't mount an immune response. And then people with head trauma, particularly with a basilar skull fracture. Why? Because if you have existing bacteria sitting in your sinuses that you might just be colonized with or might have a minor infectious process with, when that skull breaks, that solid barrier there is no longer there to protect you. And so the bacteria can cross through that break in that barrier and become an infectious process in the central nervous system. Neisseria is a pretty deadly form of meningitis. It has decreased because we do have immunizations for this, and we'll cover that in pediatrics. But we still do see this. The vaccine does not contain the serogroup B, which is responsible for 1/3 of these cases of meningococcal disease. So when you hear Neisseria meningitis, you want to also think meningococcal. Those terms should be used like synonymously, just like before with strep pneumo, we call it pneumococcal. The hallmark of this type of meningitis, so the organism causing this meningitis, is going to be petechia or purpura rash. Any person that you see coming in with like large areas of purpura with fevers and like stiff neck or altered mental status, that is like meningococcal until proven otherwise. And you need to make sure that you're protecting yourself by wearing a mask and proper body substance isolation so that you're not subjecting yourself to this organism as well. Fulminant disease can happen within hours. So this is the pretty deadly form of meningitis that you're going to see out there. And this is why, because it can become so fulminant within a few hours, it is imperative that you get empiric antibiotic therapy started as soon as possible. How do you get this? Well, you can actually have nasopharyngeal colonization of this organism, and it can just be living there and not really causing a pathogenic process for you. But all it takes is a change in your environment or any type of other process that can suddenly take that bacteria and make it pathogenic for you pretty quickly, particularly in people who have a depressed immune system or just depending on how invasive the bacteria itself wants to be. But it's kind of scary to think that this is out there and we could be colonized with it, and it can become a pathogenic process for us at any time, and it can be pretty invasive pretty quickly, and it can kill you fast. Here's a picture of what the purpura would look like. You see this particularly like in a kid. I mean, here's the scenario. A kid gets brought in by their parents, and they're saying, my kid has got a fever, he's not acting appropriate, he's complaining of a stiff neck, and he's got this rash all over his body. I mean, it's just screaming at you, meningococcal meningitis. And so that's going to be real important that kid get a thorough evaluation quickly, and empiric antibiotics are started. I can't stress that to you enough. There's enteric gram-negative bacilli, which is just a general category of organisms that can cause meningitis. So these cause meningitis in people with like chronic and debilitating diseases like diabetes, cirrhosis, alcoholism, chronic UTIs. Because they already have this depressed immune system from their underlying chronic diseases, they tend to be colonized with this bacteria all the time. And so, once again, if it can spread into the central nervous system, then you're going to have an infectious process here, and that's going to be a real problem for you. In addition, patients who have had some type of neurosurgical procedure, they can get these gram-negative meningitises because of a break in sterility or a complex wound infection, whatever. But that increases your risk of getting this type of organism to cause this infection. And remember, enteric gram-negative bacilla is just a general category here. It's not a specific microbe. Group B strep was previously responsible for meningitis predominantly in neonates. However, we're starting to see less of that. We are seeing it in increased frequency in people greater than the age of 50. Once again, especially those with chronic diseases, because most of them have some type of a suppression to their immune system. Listeria is an increasing cause of meningitis in neonates. So these two things here, Group B strep and Listeria, these are going to be common PIMP questions that you're going to get asked on your pediatric rotation when someone says to you, what's going to be the most common cause of sepsis or meningitis in a neonate. Some of it's going to be viral processes too, but Group B strep and Listeria should be the two organisms that just kind of fall out of your mouth when you're asked this question. So with Listeria, we're seeing it particularly in neonates, pregnant women, and people over the age of 60, and especially those who are immunocompromised. It's interesting. You'll learn about this when you get infectious disease, but Listeria is commonly found in things like coleslaw, milk, soft cheeses. Lunch meat is like a chronic or a buzzword. If you ever get asked the question, a patient comes in complaining of like some type of a food poisoning thing, or they've been eating a lot of processed meats, processed foods. Listeria's got to be one of the organisms that kind of moves to the front of the list here as what could be a possible cause for that. H. flu, like I mentioned before, it has dramatically decreased as a cause of meningitis, and infections in general. I mean, H. flu is a huge cause of epiglottitis, but we've seen reductions in it, particularly because of vaccines that are available now. Now, there are a lot of parents that choose not to vaccinate their children in this country, and because of that, some of these organisms and these illnesses are still prevalent. So don't get the idea in your head that, well, it can't possibly be H. flu. It's not that it can't be H. flu. It's just it's more one of the unlikely causes of it. But remember, these organisms are still out there, and people still refuse to get vaccinations against it. So we still have to be cognizant of it. Staph aureus, my goodness, staph lives on everything. You've got staph on your skin. You've heard the term staph infection. It's a pretty common organism. And so we see this a lot after any type of surgical procedure, but because we're talking about meningitis, we'll say neurosurgical procedure because it lives on our skin. And if we didn't properly decontaminate the area before we did a lumbar puncture or we did some type of procedure, a craniotomy, then that runs the risk of becoming an infectious process. The other thing too is that, even though the wound is closed, if you get staph in that wound and that wound becomes infected, it runs the risk of becoming dehisced, meaning the infection will cause the wound to erupt and open up. So you have to be careful with that and consider Staph aureus as a possible cause as well. This is where getting a culture is going to be real important because it's going to help identify the organism and you're going to be able to choose the appropriate antibiotic therapy. Okay, pathophysiology here. So we're kind of on a new topic now. We gave you some of the common organisms that you're going to see, but here's the pathophys. Now, the most common organisms that we're going to find is going to be this Neisseria and Strep pneumo. So it's typically, these organisms are colonized in the nasopharynx. So they're sitting in there all the time. And they attach themselves to these epithelial cells, these like skin cells that are sitting inside there. They get transported in vacuoles into the intravascular space or directly invade the vascular space by creating separations in the columnar epithelial cells. So they're one way or another, they're trying to get their way in. Once they're in the bloodstream, typically they would go through phagocytosis. However, these particular organisms are what's known as encapsulated. So they have a polysaccharide capsule around them which gives them protection. And because of that, it makes phagocytosis much more difficult. This is where having things like the spleen and stuff is going to be helpful to you. But if you're asplenic, then you're not going to be able to fight off these organisms as well. The nice part about this is that we have vaccines to prevent us from having these types of organisms cause infections in us. Now, the pneumococcal vaccine is typically only recommended in people who are immunocompromised, people who have had their spleen removed or who are functionally asplenic, such as sickle cell folks, and generally people over the age of, I think it's like 60 to 65. But for most of us who are healthy people, we have a decent immune system and we can kind of take care of these things. It's when these organisms overload our system and they become pathogenic to us that we have a problem. Now they can, like strep pneumo, that can cause pneumonia for us, or sinusitis, or an otitis media, and or even a strep throat. And we can take antibiotics and have that fixed. Where we have to be careful is when these when these organisms get out of control or get into the central nervous system. That's when we run into trouble. So the bloodborne bacteria reaches the intraventricular choroid plexus. Okay, so that's inside the brain. This is where your CSF is made. All right, so they go through the vascular system, and once they're in the vascular system, they're going to hit the ventricular system inside the brain where the CSF is made. They're going to directly infect the epithelial cells in there, and that's how they're going to gain access into the cerebrospinal fluid. Once they're in the cerebrospinal fluid, the bacteria can just rapidly multiply because inside CSF, we don't have the immune defenses that you have inside of your bloodstream. We don't have the white blood cells and everything else that kind of sit in our bloodstream. There are white blood cells that sit in CSF, but not in the magnitude that we have inside of our vascular system. The same thing too, things like immunoglobulins and complements, there's just not enough of them in there to mount a huge inflammatory response to fight off this infection. So because of the nature of the fluid of CSF, some of the white blood cells can't function as well as what they normally do within the environment of the vascular system. And so because of that, phagocytosis becomes even more impaired. So this is just basically we're set up for disaster if we get an infection inside the central nervous system, because we don't have the resources available to fight it off, and it takes a while to get the resources that are available in our body there to help fight it off. So this is why it becomes such a life-threatening infection so quickly. So the invading bacteria do create an inflammatory response, but like I said, it's initially not as high as we'd like it to be. Many neurosigns and complications of bacterial meningitis result from the immune response to the bacteria rather than from direct bacteria-induced tissue injury. In other words, if the bacteria itself is cytotoxic or releases a cytotoxin, it's going to destroy cells in that area. That's not what we're really worried about here. Where you see the neurosymptoms and the complaints that the patients have, such as headache, focal neurodeficits, changes in mental status, it's because of the inflammatory reaction. And I've said this many times to you. You're going to get swelling, you're going to get edema, you're going to get that inflammatory response, and on your skin or somewhere else in your body, it can swell and it can expand because you have the room to do that. You don't have the room to do that inside the central nervous system. You've got a spinal cord that's encapsulated inside of the spine, and you've got a brain that's encapsulated inside the cranial cavity. And they don't allow room for you to grow. They don't allow room for swelling. So as that inflammatory reaction takes place, you're going to get swelling and you're going to get these neurosymptoms. It's interesting here that even if you would give antibiotic therapy to these patients and clear out the CSF of these organisms, you can still have neurologic injury take place. Why? Because if you have swelling to the point where you have ischemic tissue and it causes a little stroke or it damages tissue, that's it. It's done. It doesn't regenerate. So once again, getting the antibacterial therapy on board as quickly as possible is going to be so key here. The bottom point here, the lysis of bacteria and release of cell wall components into the subarachnoid space is the initial step that causes the inflammatory process. So once those cells are broken down and your body senses these cell wall components in there, and it's probably releasing things like tissue factor and other components, and once that happens, that's what stimulates the inflammatory process there. And as those white blood cells start to fight, and their cell walls are broken down too from them lysing, from their fighting of the process, you're going to get this purulent exudate inside the subarachnoid space. That'll be apparent to you when you do a lumbar puncture, because you're going to be able to see signs of this on a CSF culture and or when you're looking at your cell count. Okay, so pathophys. So the cell wall components, they induce meningeal inflammation, like I just mentioned. And so that stimulates the whole inflammatory process of the cytokines. So cytokines such as like tumor necrosis factor and interleukin, these are present within the cerebral spinal fluid within 1 to 2 hours of these cell walls breaking down. This is why patients who come in who are acutely symptomatic, you can do a lumbar puncture on them and get an idea of what's going on. There's an infectious process taking place because of these cytokines that are present. Once these cytokines become apparent, this is going to increase the CSF protein concentration and leukocytosis. Remember, all of these factors are made up of proteins. So when you look at your protein count on a cerebral spinal fluid analysis, you will see elevated protein there. That's an indicator to you that there is an inflammatory / infectious process taking place. So that's going to be a key laboratory component for you, that if someone reports to you the protein is elevated, you got to think inflammatory / infectious process here. Tumor necrosis factor and interleukin work synergistically. Okay, so when the two of them are together, it just magnifies the process. And the two of them together increase the permeability of the blood-brain barrier. That's your protective layer there. But if we start putting little holes in it and allowing other things to come in, that's where we run into problems. So what happens here is the permeability of the blood-brain barrier becomes increased. And now you get edema and you get leakage of serum proteins into the subarachnoid space. So not only are these components made of protein, which gives you increased protein, but now you've got a leaky membrane that's allowing other fluid to leak in that also has serum proteins in it. And so now your protein count is even going to be higher. So like I said before, you look at the CSF analysis and you see elevated protein, you know you've got a problem. The subarachnoid exudate, aka pus, obstructs the flow of CSF. So remember, CSF's got to continually be moving and draining. But if you've got a lot of sludge in there, pus, that's going to back up in there. And that can lead to what's called hydrocephalus, meaning you've got extra water filling up in the ventricles. That is going to increase your edema even further. So not only do you have swelling from the inflammatory process, but your body's mechanism for trying to relieve that extra fluid in there becomes obstructed because of the purulent drainage and the infectious process. The inflammatory cytokines promote leukocyte adherence to the vascular endothelial cells and migration into the CSF. So the white blood cells become sticky, they'll stick to the cells, and because of the increased permeability of the blood-brain barrier, the white blood cells are able to flow in now. Now this is good and it's bad because they can help fight off the infection, but remember, they're going to die off, they're going to lyse, and their components are going to stay there behind, and that's what gives you the pus in an infection. It's the broken down white blood cells. So it's good and it's bad because as that pus builds up, you're going to have more obstructive process taking place there, and you can have actually increased swelling as a result. It's kind of a catch-22 here. Neutrophils, they degranulate, and that results in the toxic metabolites that are being released, and once again, it increases edema, cell injury, and death, kind of like what I was just mentioning there before. So in the early stages of meningitis, you have increased cerebral blood flow, which is good. It's followed by, though, a decrease in blood flow and loss of autoregulation because of the swelling taking place. So you get narrowing of the large arteries at the base of the brain, and that's because of the purulent exudate moving towards them, and it creates that obstructive process in the subarachnoid space. You get infiltration of the arterial walls by the inflammatory cells, which leads to them thickening, and you get a vasculitis. This can lead to ischemia and infarction. So if this isn't mind-boggling enough, you have multiple processes taking place here that are helping you and hurting you at the same time, because you have an increased permeability of the blood-brain barrier. You have cytokines that are there that are causing that to happen. So they induce the inflammatory response. White blood cells rush through there. They start fighting off the infection. You got all these cytotoxic mediators being released, and that causes further swelling and further pus to be produced. That's a problem because that increases your intracranial pressure. Now those things start to encroach the vascular tissue. The vascular tissue is getting pressure on it because of the swelling in the brain, so you get reduced blood flow there. But as these inflammatory mediators get near the vascular tissue as well, that tissue becomes inflamed. Remember, the tissue in your body, whether it's brain, skin, arteries, whatever it is, if it comes in contact with the inflammatory process, it becomes inflamed too. Remember, these cytokines and the inflammatory reaction is not discriminatory against just the brain tissue or the meningeal tissue. It's whatever's in its way as well will become inflamed. So you've got a lot of vascular tissue in there, and if the cytokines get near that and the inflammatory reaction gets near that, then you get swelling of the vascular tissue as well, and you get a vasculitis. But understand that these vessels are already being crunched down by the swelling in the brain, and now you make those vessels get thicker as well, and it makes the cerebral blood flow reduced quite a bit. And so, yeah, can they get a stroke from this or they get ischemia from this? Absolutely. The combination here of interstitial, vasogenic, meaning coming from the vascular system, and cytotoxic edema. So remember, as I was just trying to tell you before, we've got multiple processes here trying to help this, but like I said, it kind of hurts you in the process. But as that edema gets worse, it can certainly raise the intracranial pressure and lead to coma. And as I mentioned multiple times, if you don't take care of that, cerebral herniation is going to happen. So we've got to get that swelling down and get this infectious process under control because it will kill you. This is a chart from your textbook, Harrison's, on kind of this process here and kind of gives you an idea. You can pause the video and spend some time taking a look at it. You should be familiar with this, but this gives you a pretty good breakdown of the pathophysiological process here. So you get invasion of the pathogen. So you got multiple organisms and you get lysis of the organisms by bacterial antibiotics. Now I'm putting my mouse over this slide right now. I don't know if it's recording it or not, so I don't know if you can see it, but hope maybe you can. You get a release of the bacterial cell wall components. All right, that's the third point down because we're starting to fight this infection. So we produce inflammatory cytokines, and that gives us a whole bunch of issues here then. So we get altered blood-brain barrier permeability. We get adherence of leukocytes to the cerebral capillary endothelial cells. We also get alterations in cerebral blood flow, and we get production of excitatory like amino acids and all of these other things that we say, oh my goodness, there's an infectious process, and then the cavalry starts coming in. And if you follow these down here, it kind of goes through everything that I mentioned on the previous slides, but it gives it to you in a more structured, step-by-step process. So if the pathophysiology portion of this to you was a little overwhelming, that's fine. You can go back and listen to it again, review the slides, or look at this photo here and take it step by step so you can understand the process here. So I'm trying to help you organize your thoughts a little bit better by putting this photo here for you. All right, I'm going to move on. Clinical presentation of bacterial meningitis. The classic triad here has got to be fever, headache, and nuchal rigidity. Nuchal rigidity meaning aka stiff neck, or you can't move your neck or whatever, you're complaining of neck pain, all those things. Now there are clinical signs that you can look for. You'll learn things in your history and physical exam class on how to test for these signs of nuchal rigidity. But the classic triad may not be present. All right. In fact, excuse me. Decreased signs of consciousness can be present in about 75% of patients. And that may be the only sign that you see when they come into the emergency room. You just might find somebody that comes in with a comatose appearance and fever. And so now you got to go through the 1,000,001 differentials as to why they're here with a fever and altered mental status. And meningitis should always be one of the top differentials that you're considering here. There can be other infectious processes that are causing this, and maybe they're unresponsive because they're just septic. But you need to always think meningitis as a process here. So they complain of a fever or either a headache. A lot of them will complain of a stiff neck. That's like the hallmark. Someone coming in complaining of fever and stiff neck, you got to think meningitis. Or an altered level of consciousness. That's what ALOC means there. They can complain of nausea, vomiting, and photophobia. Those are common complaints, and those should give you indications that you've got some, maybe a little bit of mild increased ICP going on there. Seizures can occur in about 20-40%, and a lot of times it's the initial presentation. But once again, this becomes confusing because is it somebody coming in with a febrile seizure, and the reason why they seized is because of the fever, or are they coming in seizing because they've got meningitis? This is why medicine is so gray. It's not black and white, and you got to be the detective here and try and figure it out. Raised intracranial pressure is an expected complication of bacterial meningitis. Hello, I've been stressing that now for the past 20 slides. So keep your brains aware of this and have a high index of suspicion. Signs of increased ICP, we talked about Cushing's reflex there before, but other things you're going to see is an altered mental status, papilledema. If you do an eye exam, you can also see a poor dilated reactive pupils, and you can see 6 cranial nerve palsies. If you're seeing that cerebral posturing, we talked about that before, that's a bad sign. Herniation is on its way. So you need to move quickly with these patients. But even then, if they're coming in and they're unresponsive and they're posturing already, their prognosis is pretty bad at this point. Obviously, the most disastrous complication is herniation, and I've been stressing that slide after slide here to you. Okay, so the clinical features, as we mentioned thus far, should give you an idea. Now, some clinical features can give you an idea of what organism is causing this. The most important is going to be the rash of meningococcemia, like I was showing you before, that purpura rash. It can look like a viral exanthem sometimes. When it first starts out as this, was known as an erythematous maculopapular rash, which is like every kid you see in the emergency room that comes in with a viral exanthem looks like this. And that's just like red, kind of circular, sometimes raised bumps on the body, and they're all over the place. But they'll change. They'll go from like these little red bumps to like petechial bumps. And they don't blanch. And then they're going to spread to like patches, which are like more like purpura as opposed to petechia, which are like little dots. These become like patches of purple. And when you stick your thumb on them or your finger on them to see if it blanches, it doesn't. So it's typically found on the trunk and the lower extremities. You'll see it in the mucosal membranes and the conjunctiva, and sometimes on the palms and the soles. Now here, let me show you a picture of what I'm talking about. This poor kid is sick. And when you see this image, burn this into your brain. Because a kid or an adult that presents to you with this type of rash, with fever, altered mental status, stiff neck, focal neurosymptoms, my God, it's screaming at you that this is bacterial meningitis. First order of business is protect yourself. Get a mask on yourself. Make sure you're wearing gloves. Isolate this patient from everybody else to make sure that this doesn't get spread, that it gets contained quickly. And then the next big things are going to be you try and get a lumbar puncture on them. But remember, if they've got increased ICP, you can't go ahead and stab that CSF, because remember, you put a needle in that layer and it's like opening up a pressure valve and they'll herniate. We talked about that with strokes. So be careful here. If it looks like they've got like a Cushing's reflex going on or they're posturing and that kind of stuff, we got to figure out some other options here before we're going to go ahead. I mean, yeah, you need the fluid, absolutely, but we don't want to kill them by herniating their brain at the same time. So we'll talk about that in the next slide here. All right, so diagnosis. If you suspect it, you immediately obtain blood cultures. That's going to be your important one here. So blood cultures. And then you initiate antibiotic therapy right away. Dexamethasone is a steroid that you can use. And if you suspect that there's significant swelling in the brain, aka focal neurodeficits, they're unconscious, then you get them a dose of steroids on board. Now, steroids is going to take up to 6 hours for them to work. So you're not going to give them steroids and 10 minutes from now expect to see a huge difference. But you get it on board. The sooner you get it on board, the sooner it can start working. The diagnosis of bacterial meningitis is made by examining the cerebrospinal fluid. However, you're going to make a clinical diagnosis based on the history and presentation that you're seeing. And you're going to assume the worst and hope for the best. Okay, now, the need for neuroimaging prior to a lumbar puncture does require clinical judgment. In an immunocompetent patient, meaning you and me, we got a functioning immune system, without history of a recent head trauma, a patient who has normal level of consciousness and no evidence of papilledema or focal neurodeficits, it is considered safe to do an LP without imaging first. I'll stress that again. In an immunocompetent patient like you and me, who doesn't have any altered level of consciousness, has not had any recent history of head trauma, and who has no focal neurodeficits or papilledema, aka signs of increased ICP, you can do the LP first without imaging. We'll say, well, why do we need the imaging? Because if you got significant swelling going on in the brain and things are starting to move towards herniation, you're going to see that on imaging. Your radiologist will be able to see, hey, parts of the brain here are really swollen and it's moving really close to the foramen magnum right now. And that's going to let you know what you're going to do here. You say, well, what should I do? Should I not do the LP? Well, not at the moment, because you could kill them. But you get the empiric antibiotic therapy started. We can deal with the other issues later. They need this stuff quickly. And I know that that's kind of a crappy way to make the diagnosis, but you have to do the intervention here. This is one of those situations where you're going to have to react before you have all the data. Because if you miss the window of opportunity, your patient's going to die no matter what. So this is where good clinical judgment is going to be pivotal here. So if you think they've got it and you're worried about increased ICP, don't LP them. Get the CT, but get the antibiotics on board. If the LP is delayed for neuroimaging, you obtain the blood cultures, because at least we've got some kind of cultures here cooking, and initiate antibiotic therapy. So that's what we're going to do here, okay? If you have to delay the LP because you're worried about increased ICP, and you're going to send them off for neuroimaging, then get blood cultures first before you ship them out of your ER and get antibiotics started. If antibiotic therapy is initiated within a few hours prior to the lumbar puncture, it does not significantly alter the CSF white blood count, glucose concentration, or prevent visualization of the organism on gram stain. So in other words, the antibiotics have got to be in your system for a while for it to fight the infection, for you to see laboratory values change. So I know you're going to learn throughout your career that you always get the cultures first and then initiate antibiotic therapy. But in this instance here, if you can't get the LP right away because you're worried about herniation, then you get blood cultures and start antibiotics. I can't stress that to you enough. Get the blood culture, start the antibiotic. We'll deal with the LP later. Now, if they don't have any signs of increased ICP and they're awake and they're alert and oriented, they don't have any focal neural deficits, then you get the LP first. That's important, along with blood cultures. But once you've got the spinal tap done and blood cultures obtained, you start empiric antibiotics. All right, so here's the classic cerebral spinal fluid abnormalities. Notice that it is in red. You're going to see increased polymorphonuclear leukocytes, aka neutrophils. So when you look at your CSF smear, or the differential on the cell count, you're going to see neutrophils through the roof. And you should know this from going through your CBCs recently, that neutrophils increased tells you bacterial infection. You're going to see a decrease in glucose concentration and or CSF serum glucose ratio. I don't see a lot of people getting that. I'm sure it prints out on the lab slip, but the key thing you want to remember here is a decrease in glucose concentration. You'll see an increase in protein concentration, and as I mentioned that before. Why? Because the inflammatory mediators are all made of proteins, and as the blood-brain barrier increases in permeability, more proteins kind of flow in there. The other factor here is what's called an opening pressure. And for your purposes here, it's going to be greater than 180 millimeters of water. When we do an LP, and you'll learn this in your procedures class, we put this manometer at the needle, and we measure the pressure of the CSF coming out when we first do that. Because of the bacterial infection and everything taking place there, you will have an increased pressure that's coming out that we measure. So it's greater than 180. From this fluid here, CSF bacterial cultures are positive in greater than 80% of the patients, and the gram stain demonstrates the organisms in greater than 60%. So in a significant population, these patients were able to have positive cultures and identify the family or the exact organism that's causing this, and that can help us focus down our antibiotic therapy. So almost all patients with bacterial meningitis will have some type of neuroimaging. Why? Because we've got patients with focal neurodeficits, with signs of increased ICP. We want to take a look at what's going on there. The other reason you say, well, gee, it's probably just meningitis. Do you really need the imaging? Well, yeah, because you don't know 100% that it's meningitis. We're making the clinical diagnosis that it's meningitis, but you don't know that there's like a big brain abscess in there that's causing these symptoms either. So you need the neuroimaging to make sure it's not a brain abscess or something else that's causing this process. MRI is preferred over CAT scan because it is better at showing us cerebral edema and ischemia. However, we all know that MRI takes a long time. So it's not diagnostic for meningitis. It just helps us see some of these things better. Petechial rash can be biopsied, believe it or not. And if you biopsy the rash, you should see meningococcemia in there. And so right away, that can help you make your diagnosis, at least give you the definitive answer. So treatment. Bacterial meningitis, as I mentioned like 100 times in this presentation, is a medical emergency. Empiric antibiotic therapy should begin within 60 minutes of ED arrival. I would know that, okay? I would test you on that. Antibiotic therapy is initiated before the gram stain results are back. If you're going to sit there and be an idiot and say, well, I think they've got meningitis, but I want to wait for the labs to come back, then you don't deserve to be practicing medicine, okay? You need to recognize this medical emergency, get the tests ordered, and then get the antibiotics started, all right? Because this is a life-threatening infection. Now, you can do a combination of different medicines. This dexamethasone, you can do it, you cannot do it. There's some mixed data out there on it, but for the purposes of what you're learning here, learn that they should get steroids to bring that swelling down. There's a variety of antibiotics that you can use. You can use a third or fourth generation cephalosporin. You can use vancomycin. If you think that this is viral meningitis, because you're not sure, because you don't have your gram stain back. Remember, you're just doing empiric therapy right now. So we don't know if this is bacterial or viral. We just recognize that there's meningitis and we got to get stuff started. So you could do acyclovir as an antiviral agent. That way you're covering both your viral base and your bacterial base. Doxycycline during tick season, which here in this area, it's large. We see a lot of tick-borne diseases here. That'll cover you for that one. And then ampicillin should be used for patients less than 3 months of age or age greater than 55 or anybody with a chronic immunosuppressive process. So have a general idea that you want to do dexamethasone and a third or fourth generation cephalosporin. You could add vancomycin if you want. You should consider an antiviral agent if you're not sure if this is viral versus bacterial meningitis. Doxycycline for tick season, and then ampicillin for people less than 3 months or over 55 or anybody with immunosuppression. All right, guys. The best part about doing this recording is that you can pause it at any time and go take a break. I literally have been away from the computer now for an hour and a half out snow blowing the foot of snow that's outside. So anyway, so I'm going to move on here, but feel free to pause the video and take a break anytime, come back to it, go backwards, and if something wasn't clear for you, and listen to it again. Write stuff down so you can come and ask me questions. But hopefully this is working out well for you here. So prognosis here with bacterial meningitis. The mortality rate is about 3 to 7% for H flu, but also for meningococcal and group B strep. Now you say, why not maybe higher for those particular organisms? Well, we've got good antibiotics that can treat those, and the meningococcal we can recognize earlier because of that purple rash. Strep pneumo is more commonly seen, and therefore the mortality rate's more associated with that one because it's the more common one, if that makes sense. And then about 15% are of mortality rate with listeria. Risk of death increases with any of these following things here, like particularly decreased level of consciousness on admission. That's a marker for higher mortality rate. An onset of seizure within 24 hours of admission, once again, increases your risk of death with this. Young age or older age, comorbid factors, people with underlying diabetes or immunocompromised syndromes, renal failure, all those things are going to complicate the illness itself and make it harder to heal, and thus increases your risk of death. Shock from sepsis, and any type of need for mechanical ventilation. Anybody who gets intubated, your risk of death immediately increases because it's always the thought of are we ever going to be able to get you off the vent once we get you on it. Delaying diagnosis and treatment. I've been stressing it to you throughout the presentation that you can't miss this. This is one of those things that you can't miss. You need to have a high index of suspicion for it and then be very aggressive with it. So moderate to severe problems occur in about 25% of people, and these can be anything from like mental impairment, memory problems. People can actually damage areas of their brain from either infarction or just from cellular death from the infection, and that can make them prone to seizures. People can have hearing loss because if you damage nerve fibers that help with auditory function, dizziness, gait disturbances, if you hit the cerebellum. So it all depends on how early the diagnosis is made and what particular areas of the brain are being involved. All right, we're moving on here to a new topic now. This is viral meningitis as opposed to bacterial meningitis. So this is caused by viruses. In an immunocompetent adult, patients with viral meningitis typically present with headache and fever. So just like bacterial meningitis, signs of meningeal irritation, aka nuchal rigidity, neck stiffness, and then inflammatory CSF profile. We're saying, geez, this looks just like a bacterial meningitis, so how do you differentiate the two? Well, we'll get into that in a few minutes. The headache is almost universally present. Everybody comes in with a headache, and it can be in various locations. It can be frontal, it can be retroorbital. It doesn't have to simply be in one spot to be pathognomonic of meningitis. Every person is different, so they're going to complain of headache in different areas. They may or may not have photophobia. They may or may not have pain with movement of the eyes. Nuchal rigidity, aka your neck stiffness and inability to move the neck, is going to be present in most cases. Why? Because you have irritation of the meninges, which go up through the spinal cord of the neck. They also typically have constitutional signs that you'd see in any type of infectious process, such as muscle aches, fatigue, anorexia, nausea, vomiting. That should be nausea, vomiting, not NA, and diarrhea. Mild lethargy or drowsiness is typical, but it can progress to altered level of consciousness, coma, marked confusion. Once again, those things, I'm sorry. Let me step back here a second. Things like lethargy and drowsiness are often present. However, the stuporous coma that you typically can see in bacterial meningitis is not common in viral meningitis. If you're seeing those types of things, then you got to worry about encephalitis, where the actual brain tissue itself is inflamed, the parenchyma. You have infection in the parenchyma. Seizures, focal neural deficits, and abnormal neuroimaging is not typically seen with viral meningitis. You still are going to get the neuroimaging, though, because patient presents with fever, headache, and focal neural symptoms. You got to make sure there's not an abscess in that brain. So the typical viruses that cause viral meningitis would be like enteroviruses, and there's a bunch of them, herpes simplex virus, particularly type 2, HIV, and arboviruses. CSF cultures are positive in about 30 to 70% of patients. Now that's a viral culture that you have to do. But about 2/3 of these cultures are negative cases of what we call aseptic meningitis. And so we don't have a specific etiology of it. We know it's not bacterial, but we're not always able to identify the exact viral pathogen in about 2/3 of the cases. That's pretty significant. Viral meningitis is not nationally reported, unlike bacterial meningitis. It's estimated about 75,000 cases per year, and it can be found in different areas, but temperate climates particularly, and we notice a surge of it typically during summer and early fall. Laboratory diagnosis, we're going to do a CSF exam again, so they're going to get a lumbar puncture. Here's the difference, okay? Now it says here it's the most important test in diagnosing viral meningitis. Same deal with bacterial meningitis. A CSF fluid analysis and culture is going to be the most important test here. Here are the findings. You have increased lymphocytes. Now that's different than bacterial meningitis because in bacterial meningitis you have increased neutrophils. So anytime you see increased neutrophils, whether it's on a CBC or anywhere else, you got to think, okay, those are the first areas that they're fighting. And if you don't see lymphocytes increase, then it's probably bacterial infection. But lymphocytes are going to be running rampant in a viral etiology of the illness. So we've got increased lymphocytes here. You may or may not have increased neutrophils, but you're really going to notice a huge surge in your lymphocytes. You have normal or slightly elevated protein, as opposed to bacterial meningitis, where you have a significantly elevated protein. Normal glucose, which, if you recall, in bacterial meningitis, we have decreased glucose. And then you may have a normal or mildly elevated opening pressure, which is also different than bacterial meningitis because that typically is greater than 180 millimeters of water. So right now, just based on the CSF exam alone, you can differentiate viral meningitis from bacterial meningitis. So go back and look at the slide on diagnosing the CSF for bacterial meningitis and compare the two, because it would be a common thing to see on a test where we'd give you CSF exam findings and you'd have to differentiate between bacterial and viral meningitis. All right? Organisms are not seen on gram stain because we're not using viral stuff for gram stains. That's for bacterial testing. And like I mentioned before, increased neutrophils can be seen in about 48 hours, but they don't have to be. You typically see it in viruses such as the echovirus, West Nile virus, but it's not specific. What you're really looking for here is this increased lymphocytes. All right, so PCR amplification, or this polymerase chain reaction, basically what they do is they look for the DNA in the virus, and they can detect what virus it is through their DNA and RNA. So using this PCR amplification, and when you order these tests in the hospital, when you look at your CSF order set, it'll say something like viral PCA on there. And you'll just click it, and it's going to look for a whole bunch of viruses, or at least the most common ones. So it'll look for things like enteroviruses, herpes simplex, cytomegalovirus, and Epstein-Barr, which you guys just kind of learned a little bit about in diagnostics. So those things can certainly cause viral meningitis. Herpes zoster, the human herpes simplex virus, and West Nile virus. Not as sensitive, but it can be picked up. Now, there's viral cultures that you can actually do where you grow the virus in a petri dish, but these are not as reliable. The sensitivity for these things is not so good for diagnosing meningitis or encephalitis for that matter. So they can be detected, and you do this just like with other swabs for the other places that you're looking for. Like, if we're looking for a flu virus, we swab the inside of the nose and we check for that. But the presence of these viruses in other locations doesn't mean that that's the cause of your meningitis. So you're better off with the PCR as opposed to the viral culture, although most places will still order the viral culture. Now you can do serology studies where they basically draw a tube of blood off and they're going to look for biomarkers to see if you've had the viral infection. Typically, all of you have had the hepatitis B vaccine, so now what they'll do is they'll draw a titer to make sure that you have immunity, that you've developed antibodies against hepatitis. Well, they can do the same thing here too. They can look at your IgM and your IgG to see, if you're currently being infected with the virus versus you've had it before in the past. You can do that here to help make your diagnosis of viral meningitis. So the treatment, once you've made your diagnosis, it's going to be primarily symptomatic. This is not typically a life-threatening infection. It can be, but not typically. So analgesics for pain, antipyretics to keep their fevers down, antiemetics to keep them from vomiting, lots of fluids, just like you would for any other viral illness. Hospitalization becomes a a tough decision. Do you need it? Do you not need it? That's going to be based on clinical judgment and the patient's presentation. Patient like you and me, a healthy adult without a significant amount of comorbidities, who has a supportive family at home that can keep an eye on you and that kind of stuff, yeah, you're probably going to be okay to go home. The 75-year-old renal failure diabetic patient who has a history of bladder cancer, who's in remission, who lives alone on low income, status, yada 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 yada, that guy's probably staying. All right. So those are just things to consider when you keep them there. You can use oral or IV acyclovir. That's going to be probably your first line drug that you're going to go to. There are other drugs, like at the bottom of your screen here, like famciclovir and valacyclovir. You can use those as well. Acyclovir it's been out for a long time. It's a pretty cheap drug. It's pretty easy to find and not as expensive for your patients. So if you're going to treat them as PO therapy and send them home as outpatient, it's probably a cheaper drug for you to try. But you use it typically for herpes simplex virus, or you can use it for severe cases of Epstein-Barr or varicella zoster. But most people are treating the herpes simplex as the potential viral cause, and that's why you're putting them on the antiviral. HIV patients should receive highly active antiretroviral therapy. And if you got a patient with meningitis that has a history of HIV, you better be talking to your infectious disease folks to help manage that patient. And chances are those patients are going to need to be admitted, and not only are they going to be on their typical medicines, but they're probably going to kick them up a notch, because remember, these folks don't have an immune system to fight this infection off. And can it become quite serious for them? Absolutely. IV or IM immunoglobulin might be helpful, but the studies are mixed on that right now. So you could consider that to help fight the viral infection, but it is, there's not a lot of data that supports that. Pleconaril is a new drug that's out, and they're investigating it right now. They use it for different types of enteroviral infections. The clinical trials have shown that it decreases the duration of symptoms when you compare it to a placebo, but that's all we know about it so far. Vaccinations, things against like polio, mumps, and measles, in addition to the varicella zoster, that's where the money is right there. If you can do primary prevention by giving someone a vaccine to prevent these viral illnesses, then you should do that. I mean, that's just a no-brainer. So acyclovir is the agent that we'll talk about here that I'm going to make sure that you guys know for your test. It's an antiviral agent. It once it's metabolized, okay, so it's got to be metabolized first. It inhibits DNA synthesis and viral replication by competing with that word there, the deoxy. Yeah, I should sound more professional when I say this, but basically, it's going to screw up the DNA inside the virus, and it won't allow it to replicate anymore. That's really what it comes down to. Dosing is 10 mg per kg per dose, and you dose them every 8 hours for 10 days. They can get some malaise and headache from it, but guess what? They probably already came to you with those symptoms. But you should watch their renal function and their liver function while they're on it. The only contraindication is that they've had a previous allergy or hypersensitivity reaction to it in the past. So the prognosis actually is pretty good. Most patients have a full recovery. There are some rare complaints, and it's in a small area of the population that has this, that has a chronic headache or chronic mental impairment. But for the most part, everybody, if you're an immunocompetent adult, then you tend to do pretty well with this. You feel like crap for a while, but you do tend to do well with this. Infants and neonates, we're less certain on the prognosis. Particularly the younger you are, the more likely you are to have potential problems. Now that's a two-sided coin, because the younger you are, the less of an immune system that you have working for you. But at the same time, because you're so young, you have much better ability to recover from any type of neurologic insult. So they have seen some intellectual impairment and learning disabilities, but for the most part, viral meningitis is a lot less invasive than bacterial meningitis. So you do have a better chance of a prognosis with this illness as opposed to bacterial. Encephalitis, new topic. All right, we're almost done here. We've only got about 20 more slides to go. You guys are hanging in there. I love it. If you need a break, pause the video, go to the bathroom, get something to eat, go watch a little TV, and then come back to this. Encephalitis involves the brain parenchyma itself. This could be viral illness or bacterial. So remember, just encephalitis is just a generic term for inflammation of the brain parenchyma. In contrast to meningitis, which only involves the meninges, this involves the brain tissue itself. Now, you can have a combined illness of a meningitis and encephalitis at the same time. So you have a meningoencephalitis. You can also have an encephalomyelitis, which would be the brain and spinal cord. And you can have an encephalomyeloradiculitis, which would be brain, spinal cord, and the nerve roots as well. So you can get combo illnesses. Isn't that nice? About 20,000 reported cases per year. There's actually probably a larger number than that, though, but that's what's reported. Hundreds of viruses are capable of causing this. So it's really difficult to try and figure out what is the exact etiology, but typically only a limited subset are responsible for the most cases that we at least are able to identify. The most common ones are going to be the herpes viruses, such as herpes simplex virus, varicella, that should be zoster virus, Epstein-Barr, arboviruses, and West Nile is certainly becoming a lot more known for encephalitis epidemics, and we do see that here, particularly in this area with our mosquito population. Clinical presentation: acute febrile illness. What a shock! Altered mental status. That's going to be a pretty big one there. They can go from any type of lethargy all the way up to full-blown coma, because remember, it's involving the brain parenchyma itself. Now, evidence of either focal or diffuse neurosymptoms could be related to the specific site of the inflammation or infection. So if you have occipital area, you may have some visual problems. If you have cerebellar issues, you may have some gait problems. But the most common symptoms that we typically can see is aphasia, ataxia. You can have upper or lower motor neuron weakness. You can have involuntary movements. You have cranial nerve palsies. Those are the more common symptoms. But once again, it has to do with the specific area of the brain where the inflammation is taking place. Some patients can have changes in personality or hallucinations, which would typically be more involved with frontal lobe issues here. Seizures can also happen as well. So you can see that there's a lot of similarities here between encephalitis, viral meningitis, and bacterial meningitis. So the key here is going to be some diagnostic studies to take a look. Now, there are some pathognomonic things, like we showed you the meningococcal rash. That should draw your eyes right to that. And typically the viral meningitis has a less of an acute presentation. But you got to think about all of these illnesses and your differentials when you're thinking about a central nervous system infection. So you can have involvement of the hypothalamic pituitary axis. And so you'll get temperature dysregulation. You can get diabetes insipidus, which you're going to learn about coming up next with Dr. Hellwig. And you can get syndrome of inappropriate secretion of antidiuretic hormone, which is a whole lecture in itself, which Dr. Hellwig is going to go into. Just understand that these are other things that you can see with a hypothalamic pituitary axis involvement of the encephalitis. All right, so diagnostic studies. You're going to do a lumbar puncture on these folks because, once again, you're not sure, is this a meningitis? Is this an encephalitis? So you're going to find your CSF profile is indistinguishable from that of viral meningitis. You're going to see increased lymphocytes. You're going to see maybe a mildly elevated protein and a normal glucose. So now you're scratching your head and you're going, geez, how the heck do I know if this is viral meningitis or encephalitis? Well, you're not always going to be 100% certain with that. You're going to have to look at your patient presentation. Patients with encephalitis will have more neurologic symptoms and more evidence of a decreased level of consciousness because you've actually involved the brain as opposed to the lining around the brain. And you say, okay, well, what if this is bacterial in nature? Well, a bacterial infection in the parenchyma is going to more likely be focal as opposed to generalized with a viral illness. So what we're going to get into next is going to be like a brain abscess. So that's what we'll talk about in a little bit. All right. So anyway, the increased cells seen is seen in about 95% of the cases on the initial LP. All right. And if it hasn't been seen there, then you'll definitely see it on the subsequent LPs from there. Immunocompromised patients, such as patients on chemo or steroids, they may not show an inflammatory response in their cerebrospinal fluid initially. So you might have to do it again later on to get evidence that there's an infectious process taking place there. All right, so CSF PCR, just like for viral meningitis, we're looking for a viral cause here, and we can use PCRs to identify a number of viruses such as herpes simplex, cytomegalovirus, Epstein-Barr. Now, the sensitivity varies by virus. As I was telling you on early slides, we're pretty accurate at diagnosing herpes simplex, and we're usually, treating for that pretty often. Now, the PCR for this is basically equivalent or exceeds what a brain biopsy would be, that's pretty darn accurate. However, the West Nile virus PCR is not as sensitive. But if you do that and draw like IgG and IgMs with it, then that kind of helps point you in the right direction that it's West Nile virus that could be causing it. Culture, it's limited, because like we said, we're talking about viral cultures, and as I mentioned to you before, viral cultures are not as sensitive, and plus they take a lot longer to grow than what you would a bacterial culture. Serology studies, like I just mentioned, it's this identical approach to that of viral meningitis. So you can look for IgM and IgGs and help figure out what's going to be the plan. They may be useful in patients that have low seroprevalence in the general population, like I mentioned before. It may help you with West Nile virus. Okay. Pretty useful with varicella zoster, but the PCR is not as sensitive for varicella. So, like I said, anything that the PCR is not going to be as sensitive for, you should consider serology testing. Now, in cases of herpes simplex virus, with a negative PCR, but you're like, geez, this looks like herpes simplex virus is causing this, the PCR is negative, get some serologies. Use both of them to kind of help direct you where you're going to go. So use the serology and the PCR to kind of help point you in the right direction. Imaging, everybody's going to get neuroimaging because they're coming in with neurodeficits. All right, so we're trying to see if there's an abscess, pocket of pus in there somewhere. MRI is certainly more sensitive. Why? Because, as we mentioned earlier, it's more sensitive at looking at inflammation and edema. MRI is pretty helpful in areas of herpes simplex virus infection. You can see areas of increased signal intensity in the frontal temporal lobe. And so that gives you an idea of where the infectious process might be taking place. But, it gives you a statistic here that 90% of patients with herpes simplex virus encephalitis have an abnormal MRI. MRI is not as helpful though in West Nile virus. Only about 2/3 of those patients have an abnormal MRI. All right, an electroencephalogram is typically what we use to help diagnose seizures. Think of it like as an EKG for the brain. Now, this can be helpful in the diagnosis of encephalitis because you see EEG abnormalities in a little bit over 75% of patients with documented cases of herpes simplex virus. So while you're waiting for the PCR results, if you get an EEG done, it might help you kind of move in the direction of herpes simplex virus as your etiology here. You also do see some abnormalities as well with West Nile virus. So that can at least kind of help hone down your diagnosis strategy there for you. Now, some patients require brain biopsies. This is not often, but you have patients in which you've ordered PCRs and they're negative. And you're like, geez, that doesn't help me make a diagnosis. You got an MRI, which is abnormal, and the radiologist documents that it's consistent with like viral etiology of encephalitis. You're like, all right, so I've got a negative PCR, and I've got an MRI that says it's probably a virus that's causing this. And we put them on acyclovir. But the patient's not getting any better. In fact, the patient's starting to get worse. Well, now you got to scratch your head and say, what are we missing here? And I really need a sample of that brain to know what's causing this problem here. That's when you give your friends in neurosurgery a call and say, I got a guy here with encephalitis. We've done all the tests that we can do at this point. We're not getting the answers that we need. He's on the appropriate antiviral therapy, and he's getting worse. We really need a brain biopsy. And that's when they'll go in there, and they'll take a piece out, and then you can send that parenchymal tissue to the lab for analysis. Not very commonly done, though. All right, so how are we going to treat these patients? Well, if they come in with an altered mental status or comatose, just like everybody else, we got to manage the airway, breathing, and circulation first. You can't take care of the problem if they're not breathing. Doesn't matter how bad the infection is. If they're not breathing, they're dead. So you got to keep them alive by managing the basic functions first, airway, breathing, and circulation, and then tackle the rest of the problems from there. You start them on antiviral therapy. So your acyclovir, your valcyclovir, whatever you want to choose, you're going to get them started on it. They'll probably need admission to the ICU because usually these patients have an altered mental status and they're going to need to be watched and have frequent neurochecks done. If you get neurosurgery involved because this brain swells, you could have increased ICP and you want to monitor for that. Now you can do a couple different things. You can have neurosurgery put a probe inside the cranium and measure the pressure, or you can just do frequent neurochecks. And if the neurochecks are getting worse and they're starting to get bradycardic and hypertensive and all the things in Cushing's triad that we talked about, then you can intervene. Fluid restrictions and avoiding hypotonic IV solutions. You say, well, why do I need to do that? Well, because the brain is swelling, because it's infected and it's angry. And if I give you more fluids, then you're going to potentially third space those fluids, because remember, during an infectious process, capillaries get leaky, and now if I start giving you more fluids, then you're going to just have that leak into the interstitial space, aka brain parenchyma. Same deal with hypotonic fluids. Hypotonic fluids come into the vascular space, but then the fluid portion seeps out into the interstitial space because it's hypotonic. Once again, don't want to increase any more fluid into that cranial cavity because we just don't have any room for it. Control the fever with antipyretics, your Tylenols and your Motrins. Seizure precautions and prophylaxis, you can consider that. We've talked about that with our stroke patients. Do you want to load them with Dilantin to keep them from having a seizure? You can consider that. But, you might want to just keep your Ativan or your Valium nearby in case they start having seizure activity. Airway protection, always important because these patients typically have an altered mental status. You don't want them to aspirate. If they're going to be on a ventilator for a while and they're going to be laying in a bed, you want to make sure that they don't get ulcers or pressure sores from laying in bed. And all these patients obviously need DVT prophylaxis because if they're comatose and they're in the bed, they're not moving, and blood's going to pool in their lower extremities and they're going to get a clot. So you want to make sure that they're on some low molecular weight heparin or the compression boots, whatever you can do to help prevent them from getting a deep vein thrombosis. Prognosis, it really depends on a whole bunch of stuff. I can tell you right now, patients who come in with an altered mental status, they have a poorer prognosis than somebody who's alert and oriented. So the EEE virus, 80% of survivors have severe neuro impairment. So these types of these arbor viruses, they have severe neuro impairment. Things like Epstein-Barr, they can have severe impairment, but it is rare. So, but it just depends. It depends on what virus caused it and what area of the brain it hit. Like I mentioned before, level of consciousness at the time of therapy is important. The very young and the very old, they're not going to do well. But people who have severe neuro impairment at the time of treatment, they either have died or they have severe neurodysfunction. So here's what it looks like. If you're less than 30 years old with good neurofunction, 100% survival rate. 60% with no impairment. That's not bad. But if you're older than 30, like yours truly, 64% survive, so that drops pretty significant, and 57% are left with no neurodeficits. So it's not bad statistics, But once again, it's going to be identification and getting them the appropriate treatment. All right, new topic, brain abscess. This is a pocket of pus inside the brain parenchyma. Typically, it is surrounded by some type of a vascular capsule. I'm not 100% sure. I think we're going to talk maybe a little bit about the pathophysiology behind it, but that's just the common encapsulation feature that has with this abscess. And you can see these CT scans down here that have these pockets inside of them. They're pretty clearly seen. So it's about up to 1.3 people out of 100,000 persons per year. So it's relatively uncommon, but it can happen. Look at these predisposing factors here. Otitis media, mastoiditis, sinusitis, pneumonia. Oh my goodness. These are things that we see in the family practice office every day and we treat. And they're pretty common illnesses. You're going to see ear infections in kids all the time. You're going to see sinusitis all the time and pneumonia. These are things we see this time of year. But who would think that it could lead to a life-threatening central nervous system infectious process? These simple things that you've had all your life. You get a little sinusitis, you go to the doctor, put you on an antibiotic, you get better. But can you imagine the people that don't seek medical care and let these infections go rampant? They can actually get a brain abscess from it because the sinuses are right there next to the brain. The mastoid process is right there. Now the pneumonia process, well, those organisms got to get in the bloodstream, but they'll find their way. They'll get up there. So this is a neurosurgical emergency. You've got a pocket of pus. This is basically a mass-occupying lesion in the brain. And it's pushing on the brain. You're going to have neurosymptoms with this. And can it get to a point where it can cause increased ICP and herniation? Absolutely. So it develops by a direct spread from an adjacent cranial site of an infection, aka sinusitis, otitis media, mastoiditis, even dental infections, especially in the upper dentition. Go back to your anatomy. Take a look at it, folks. The sinuses sit right next to the brain, and all you got is a little bit of thin bone between the two. And if you've got an invasive bacteria, it's going to move its way through there, no problem. And next thing you know, you're hitting the brain. These things can also happen if you've had any type of head trauma, because once, like I mentioned before, if that bone structure breaks, it's just opening up the door then for bacteria to get in there, and people who have had neurosurgical procedures. In up to 25% of infections, there's no obvious primary source of an infection. You refer to those as cryptogenic brain abscesses, meaning we don't know where the abscess came from, meaning you didn't have a sinusitis before, you didn't have an ear infection before, but suddenly you present with a brain abscess. Those are called cryptogenic brain abscesses, and they can occur in about 1 out of every 4 cases. So here's the pathophys. You get bacterial invasion into the parenchyma. You say, well, how does that happen? Well, you probably had some type of pre-existing area of ischemia or necrosis or hypoxic brain tissue. This is a theory, okay? And then because the brain tissue is generally resistant to bacteria, so that's why this is a theory. So you had some type of tissue necrosis or some type of tissue disruption there, and that's what allowed bacteria to kind of move its way in that area. Now this forms in stages, so here we go. So here's the first stage. You get this cerebritis stage that happens in about 1 to 3 days, and you get a perivascular, perivascular infiltration of inflammatory cells. So right around the vasculature, you get inflammatory cells, and that surrounds a central core of necrosis. So you get inflammatory cells that come out from the vascular tissue, and they form like a pocket. And inside the pocket, that tissue becomes necrosed. And because you got inflammatory mediators around an area of necrosis, you're going to get edema. So you start to get some swelling. Now you move from there to late cerebritis. And here you start to get pus formation from those white blood cells breaking down. So pus formation leads to an enlargement of the necrotic center because that tissue's been killed off. And you get a thin capsule of inflammatory cells that come around the pocket of pus, and your edema begins to worsen. From there, the capsule gets better structure to it, and it actually gets to a point where you can see it on neuroimaging. So that takes about 10 to 13 days for this process to happen. Once you're getting about 2 weeks and on, it's a dense, thick capsule. And you have surrounding edema, but it is getting better. But at this point, the mass-occupying lesion is so big that it's putting pressure on the brain that you could start having seizures as a result of this. So like I was mentioning before, this presents as an expanding intracranial mass rather than an infectious process. So you think the person comes in with like a head bleed as opposed to an infection per se. So it can develop up, like we were just saying, up to about 2 weeks, but most patients, right around days 11 to 12, seek their care at that point. Now let me back up the slide here, because if you look here on number 3, it says here that you get formation of the capsule at about 10 to 13 days, and now you can see that on a CAT scan, and most patients tend to come to the ER at that point, which is good for us because we can see it on CAT scan and make the diagnosis. Here is the classic clinical triad. Ironically, only seen in less than 50% of cases. Headache is the most common symptom, which makes sense because you've got this big pocket of pus pushing on your brain, so you're going to have a headache. Fever is only seen in 50% of the diagnoses. Why? Because it's a focal infection in the brain. It's not this huge diffuse infection like encephalitis. It's a focal bacterial infection. So you're not going to get as much, you're going to get inflammatory response, but it's going to be focal as opposed to global. And then you're going to get focal neurodeficits, and that has to do with where the pocket of pus is. Very similar to like a hemorrhagic stroke. Whatever area of the brain is being compromised, those are the neurosymptoms you see. So if you go back to like your stroke syndromes, anterior versus middle cerebral artery versus posterior cerebral artery, they all have like their little stroke syndromes of neuro complications. Same deal here too. If it's hitting different areas of the brain, you're going to have specific neurosymptoms that kind of direct you as to where you're going to find this mass. So hemiparesis is the most common localizing sign of a frontal lobe lesion. I'll say that again. Hemiparesis, meaning you can't feel the one side or use the one side, is the most common localizing sign of a frontal lobe lesion. Temporal lobe lesion presents with dysphagia or visual field deficit. So you're going to have changes in vision or speech with a temporal lobe. You're going to have hemiparesis with a frontal lobe. Cerebellar lesion, you're going to have nystagmus and ataxia. So those are the 3 things that you need to know about that as potentially where your brain abscess is going to be located. Now you need to look for signs of ICP. Well, that is like in every central nervous system process that we've talked about so far. Why? Because we don't want the brain to herniate. So papilledema, nausea, vomiting, changes in mental status, all you need to be thinking about increased ICP in these patients. The diagnosis is made by neuroimaging. MRI is better than CT, but if you're in an emergency room or you're in family practice, CT is certainly going to be the better or the more convenient test for identifying the abscess. But MRI is going to be better. MRI can also give you a better idea of where they are in the stages of the development of the abscess. Now, CT has been shown to be better at identifying abscesses in the posterior fossa, but most people are going to get a CT first to see what's going on, and then they're going to see this, and then they'll probably get the MRI after the fact. Culture and gram stains are going to help identify the organism, and they're going to guide your antibiotic therapy. How do you get those? You got to call a neurosurgeon. They got to open up the skull, evacuate the pocket or the abscess, and then they're going to culture it and send it to the lab. So what do you do with these patients? You got to call a neurosurgeon. This is a neurosurgical emergency. You have a mass-occupying lesion in the brain, and an infectious one at that. So you're going to call a neurosurgeon, and you're going to get these guys started on antibiotics. You're going to do a 3rd or 4th generation cephalosporin, and then you're going to add a medicine called metronidazole or Flagyl, and that's going to cover anaerobes. You'll learn more about that when you're covering infectious disease. And Nani's going to review these processes with you as well, but I'm covering it in neurology just so it'll be a good review for you when she covers it in infectious disease. Now, patients with head trauma or recent neurosurgery, you're going to use your third-generation cephalosporin and add vancomycin to that mix. So you're going to send them to the OR. They're going to aspirate and drain that abscess, and that is going to be the big part of the treatment here. You can't just put them on antibiotics and have this resolve. It's no different than if you had an abscess in your arm or on your leg or somewhere else in your body. You got to cut it open and drain the pus out. Okay, it's called an incision and drainage. So same process here. We got to open up the skull, we got to remove the pus out, and then get you on antibiotics. Prognosis, mortality rate is less than 15%. Generally because, you show up to the emergency room and, you got focal neurodeficits or neurochanges, we're immediately sending you to CAT scan because we don't know, is this a stroke, is this a brain tumor, what is it? And then we go, geez, look, you got a brain abscess. We call the neurosurgeon, we start antibiotics, you go right to the OR, and they fix it. People who don't seek medical care will get worse, but generally mortality rate is about less than 15%. Now, can you have issues long-term from this? Absolutely. Can you have permanent brain damage and permanent neurodeficits from this? Absolutely. And that is seen in greater than 20% of survivors. So, but you're going to go through neuro rehab and physical therapy, and you can get better, but you may not get 100%. But that all depends on how rapidly the lesion is identified and how quickly you get it resolved. All right, folks, hopefully you've been taking notes throughout this presentation. Certainly, I hope you've been writing questions down because we can review this information in class. But this isn't, the most part with this, just as a quick review, patient presents with maybe a headache, fever, nuchal rigidity, maybe a couple focal neurodeficits. Your first line order of business is to make them comfortable and get an LP, as long as they don't have signs of significant increased ICP. You might want to get neuroimaging first, but if they look like you and me and they're healthy people, you can probably get the LP done pretty quick. And then you're going to get them started on antibiotics because you're not sure what's going on. That CAT scan is going to help guide you. If you see a brain abscess, then you know what you're going to do. You're going to call a neurosurgeon, keep them on the antibiotics, and they're going to go to surgery. If it's encephalitis, well, then their CSF culture is going to look just like a viral CSF culture. You're going to get them on an antiviral, and they're going to need to be admitted to a neuro ICU. You need to be cautious about seizures and changes in mental status with them, so keep an eye on them. People with bacterial meningitis, they should be isolated. That's pretty serious because the mortality rate's pretty high. And we're going to get them started on empiric antibiotic therapy, but we're going to wait for the cultures to come back so we know exactly what organism we're dealing with and where to go from here. So that's basically the long and the short of it. You need to recognize these syndromes pretty quick and get moving on them because these can be life-threatening infections pretty fast. Now, viral meningitis, not so much, but it can happen. So until you're able to know for sure that it's a viral meningitis and you can kind of back off a little bit, you need to be very aggressive with these patients. Folks, I hope that this was helpful for you. You can certainly review this at any time prior to the test, and I'm happy to answer any questions that you have. Thanks for listening. Have a great day.